All right, this is probably one of my favorite all-time graphs in the book. Yes, that's a little sad, I get it, but bear with me here, okay? Because this one simple graph explains really a lot of cool things, okay? So we're looking at the titer of immunoglobulins, or the concentration of antibodies over time in a fetus, which of course is going to be everything left of where you see birth or zero, the zero time point here. And then in a neonate during that first year of life, and that's going to be everything to the right of that zero time point. And what of course you can see is the predominant immunity afforded to the fetus is through maternal IgG. And that also is a nice reminder that maternal IgG is the only antibody to cross the placenta. Then after birth, which we see here, you can see obviously that line, that maternal IgG is going to decrease. And by 6 months, the majority of it is depleted, and it's not considered completely gone until somewhere between 12 and 15 months. Okay? Now, in the interim, the infant is developing their own immune response. You can see this nice little green line here representing IgM. Also a nice reminder that IgM is always first. So we're always going to make IgM first. You can see that here, followed by IgG and eventually IgA. All right. But the thing that we want to look at first is that at 12 months, the total percentage of immunoglobulin that is made by a 1-year-old is still 60% of the adult level. So they're still pretty deficient as far as the antibodies are concerned compared to adults. That's why they're nice little germ factories around that age, right? All right, so that's the first important thing. The second important thing is that when we talk about immunodeficiency diseases, they don't typically show up until between 6 to 8 months of age, because that's when the maternal IgG is mostly gone. So that high level of maternal IgG a lot of the times can go ahead and mask an immunodeficiency in a child. So those usually don't show up till a little bit later. And the other thing we sort of want to think about is, of course, we don't give live vaccines until after 12 months because, again, that maternal IgG can still be sticking around. And if we gave the MMR vaccine, let's say back here at 4 months, what would happen? That maternal IgG would likely still have antibodies. Remember, the MMR vaccine provides usually lifelong immunity. So the antibodies that are there would probably bind up that MMR vaccine, and then the infant's immune system would never see it. So the infant really would never become immune, which is why we have to wait sort of until this 12-month period. So lots of important fun stuff from that graph. Also, just to look back again, that IgM is first. So if we're looking at antibodies to diagnose an infection in a fetus, obviously we can never use IgG because we don't know where that's coming from, right? It's more than likely coming from the mom. So the only antibody that's really useful in diagnosing infections in an infant, in a neonate particularly, or a fetus is going to be IgM. All right, so just to reiterate a few things I said when we were looking at the graph. The persistence of maternal antibody can affect vaccinations, and that's why, of course, we don't give those live attenuated vaccines until after 1 year, because those residual maternal antibodies could inhibit essentially the formation of a good immune response against those vaccines. So if you do have a kid that's really at high risk for exposure to something, we can sometimes work our way around that. But again, if we give it especially at, less than 6 months of age, we're going to need multiple boosters, of course, because the immune system's going to need a little bit more time, because a lot of that vaccine strain probably got sucked up with maternal antibodies. And as I also said, just remember, IgM is the only useful isotype of antibodies useful in diagnosing infections in neonates and also a fetus. Okay, so infants usually don't have very many infections during those first few months because of that nice high titer of maternal IgG. And as we said, that can actually mask some immunodeficiencies, which aren't going to become evident until that IgG gets to a really low level. All right. But again, when we look at the IgA response, infants, even at 1 year, have still only 20% of the adult levels of IgA, which is why breastfeeding is so important, because that can also extend the protection to that infant. So one of the things that's going to be really important for step 1 is not to memorize this vaccine schedule, okay? That is going to be important in step 2 and possibly step 3. But for step 1, we're really just going to focus on the vaccines that are in the list. So the only reason that we really even cover it is because these are the vaccines that are considered really high yield for step 1. So this is the actual schedule from the CDC. And you can see these are all the vaccines that we've sort of already talked about. So the ones that are listed here are going to be high yield. And again, you don't have to memorize dosing for step 1, although you will have to know that a little bit more for the other step exams. But I just want you to sort of take a look at a pattern. So for example, when we look at things that are not live attenuated, we have to give several doses, right? So we have to give our dose of the conjugate Haemophilus influenza type B vaccine. We have to give that at 2 months, at 4 months, 6 months. We have to give it again, so we boost again, okay? And sometimes, depending on the vaccine, we have to boost again, okay? Whereas if you take a look at the live vaccines, like the MMR vaccine, we give 1 dose, which usually provides immunity, and then the second dose for sure allows people to seroconvert, which means that they're considered immune to those pathogens. So that's really all you want to get for this. Just make sure you know the vaccines in this chart, and we're going to cover those in the next couple of tables to make sure that we know them. The bacterial vaccines that you need to know for step 1 are included in this table. The first ones listed are part of the toxoid vaccine that we talked about, the DTaP vaccine. Okay, that's part of the DTaP, diphtheria, tetanus, and acellular pertussis. And then also we have listed here our conjugate vaccines. That's Haemophilus influenza, the pediatric strep pneumo vaccine, and then the meningococcal vaccine. Now, what I'm going to tell you right now, even though we didn't have it by this version of the immunology text, is that there is a new vaccine out for the meningitis serotype B. And if you remember back to microbiology, serotype B was the most common serotype causing meningitis in the U.S. from Neisseria meningitidis. All right, so it was the serotype of meningitis causing, most of the infections from that pathogen. The problem was that the capsule wasn't immunogenic, so it was never included in the vaccine. So we vaccinate for the other 4 common serotypes that you can see there, and we never had a vaccine for B. We now do have a vaccine for B, and it was introduced, I think, very late in 2015. And now they're starting to administer that to kids sort of really before they go to college. So that's the B vaccine. It is not a capsular polysaccharide or a component vaccine because of what I just said. The polysaccharide in serotype B is non-immunogenic. So it's more of a component vaccine. They take an immunodominant protein from that serotype and used it for the vaccine. So that will be up and coming as well. And this table lists the important viral vaccines. And of course, we have a lot more of these. We have the rotavirus vaccine. This one has sort of an interesting history because we had it. It was causing intussusception, so they pulled it off the market, sort of reworked it, put it back on the market, and it seems to be a safer vaccine. Polio vaccine, of course, which I mentioned, we now exclusively use the inactivated polio vaccine or the Salk vaccine. Flu vaccine, for the most part, we use the killed vaccine, but of course my kids like the live one, because they don't have to get another needle. The VZV vaccine and the MMR vaccine, those are going to be our live attenuated vaccines here. And then our Hep A is another example of a killed vaccine. And as we mentioned just a little bit ago, the HPV and the HBV vaccines are all component vaccines. All right, so hopefully you got a lot out of this chapter. You're going to want to integrate it again with your microbiology. But again, for USMLE Step 1, vaccinations are really super high yield. So you're going to want to pay attention to this chapter and make sure you got it.